Well, we've learned a lot of lessons here, but we're about to learn some more. So this is a section on lessons learned. Our first speaker, Will Jordan, about EVAR.
Thank you, Dr. Zarens and Dr. Dake, for the invitation to be here. I can't say I have an auspicious role of being the first implanter or the first at anything except some less glamorous roles, and I'll tell you about that as we get to those in the presentation. First, we've heard from some of these pioneers, and it's really just sort of to establish that baseline of where we were in 1990 when things were happening outside the U.S., and we've heard from Juan Perotti and some of the wonderful landmark movements that he made. I think one thing I haven't heard mentioned yet about the skepticism and the naysayers, which I'll bring up here, is that Perotti's first manuscript was first rejected by JVS, and it went to Annals of Vascular Surgery. I think that's important because I want to bring up some of the other skepticism that occurred. First, we realized that the EVAR was approved for use in Europe in '95, and we were still putzing through some clinical trials here in the U.S., and this was probably my first role as a first. And here's the first endograft at Emory in 1994, so a couple years behind Stanford. But more importantly, I was not the first operator, the surgeon, that's Elliot Chaikoff, or the radiologist, the first assistant. I was actually the first photographer. I'm standing behind the camera taking the pictures here. But ultimately, this devices were approved in the U.S. in September of '99. And so what lessons did we learn? And here are 3 items that I would like you to take home from at least my presentation. First, that minimally invasive does work. Size does matter. I still believe durability is a concern because I'll show you that more revisions are required after EVAR. And finally, I would like us all to consider the aorta as a dynamic living organ. It grows or it degenerates with time. And I think that's important when you select what you're going to use in what particular environment. So making it smaller seems to work in other technologies, the telephone and the electronics industry, so why not work the same in the aorta? Again, going back to the initial approval date in '99 when we had this promise of reduced morbidity, a quicker recovery, all from this minimally invasive repair. Again, another photo from the Emory first, when we're suddenly looking at the camera instead of the patient. Now, there was, as we see this change, this shift from open reconstruction to endovascular reconstruction, there clearly were some skeptics. So 10 years after the first publication, those in England still had a healthy skepticism. They considered a failed experiment. And if you look at some of the reports, or at least how they summarize reports in the British Journal of Surgery, they could see as much as a 16% open conversion within 1 month. And again, this is in the very infancy of endovascular grafting. And there's a 20% reintervention rate at 1 year. Again, our presentations today have shown that this is not necessarily true. But these authors at this, from this editorial would not consent to endovascular repair and are astonished that so many patients have, as they might say. But I think when we look at some of those randomized trials, both EVAR-1 and DREAM, we all recognize that EVAR clearly has a better, at least short-term survival, and probably even better in the long term. And I think that is when, and again, this is 2000 to 2010 in the U.S., there was clearly some interest and engagement in endovascular reconstruction, and you can see how that clearly increased over time as the national utilization for EVAR in the U.S. Clearly grew quite a bit as the open reconstruction fell. And I also want to point out this graph that demonstrates a rather impressive decline in the mortality associated with AAA. And we can see various events that occurred, but I believe that most of this probably occurred when EVAR became at least introduced and more widespread utilization throughout the U.S. And that's why I think EVAR did have the biggest impact. Well, what lessons did we learn? First of all, I do believe that miniaturization can occur, but occasionally too small can be a problem. Certainly there's a Goldilocks phenomenon. We don't want it too big. We don't want it too small. And finally, I think that's likely related to the problems with progressive aortic disease and the environment in which the endograft stays in place. And that we can see over time that the aorta changes in relative to length, its own tortuosity. We've seen demonstrations of how it can grow and lengthen. I think that's even more well demonstrated in the thoracic aorta, and also ultimately the diameter. So let's go back to some of those randomized trials that were presented initially that I discussed, the DREAM, EVAR-1, and the ACE. And while this is not the KM plot for survival, this is the one that shows freedom from reintervention. And you can see that clearly endovascular falls below open repair because there were more reinterventions required. I believe that this is related to more often proximal progressive aortic failure that can occur also with iliac disease. But let's think about what can happen on the proximal aorta. And this is a lady that I treated first in 2000, and you can see when she finally came back to some late follow-up in 2013, she clearly had some dilation where this aneurysm graft was placed at that site. She ultimately went on to a 4-vessel snorkel or parallel graft. Here's another example of a case that treated with an endograft in 2007. This is actually a suprarenal fixation graft, and you can appreciate in 6 short years that there's dilation of this segment right above the renal artery. That's the lowest left renal artery. And I might comment, it's just not at the endograft, not the paravisceral aorta, but this is a phenomenon that can be seen throughout the entire aortic segment. Additionally, not only does the aorta fail, but the actual mechanical device can fail. These stents can fracture this old anchor graft. You've seen some of these others, and this is the endologics relative to a pulmonary stent inside, and you can see how these are zones for failure, and that's where this endo leak right there at that location. I want to take you through one of my own cases when I was pursuing this durable phenomenon. On this gentleman who was 78 at the time when I treated him in 2004, and without going through the entire scenario here, I think you all can understand this scenario in your own practice. When we go from 2004 to 2008 to 2009, 11, 13, various sorts of chasing embolization. It wasn't until 2014 when he presented with this rupture and actually got to us when he was hypotensive and renal failure, and he was sent to palliative care. So we took him from palliative care to the operating room when we identified as a type 3 endo leak. And you can appreciate these different components, and the separation is right here between. We simply put another cuff, attach this with some endo anchors that you can see help secure it both at the aorta and also graft to graft in an off-label phenomenon. But the intraoperative angio showed it was completely treated, and this gentleman continues to see me on an annual basis and has remained reasonably stable. And you can appreciate the pretty vigorous tortuosity in this lateral radiograph that shows where it turns. So ultimately what I submit to you is the aorta dilates over time. Here's another lady treated between 2002, reappeared to me in 2008 after she missed a couple of surveillance intervals. And you can appreciate how this old endograft is completely collapsed inside the aorta. And I wonder if we can do some type of intervention to prevent this dilation. Is there something we're doing? Is there something we can do to prevent it? Well, of course, going back to my surgical principles, and I need to comment that I'm happy Jason Lee got to present before me because I know he's younger than I. I wasn't in medical school in '92. I was actually a surgery resident, and so that's why I guess I'm not some of the first. So thank you, Jason. But I still like putting a stitch in the aorta, and I think that this potentially is one way to solve the problem. Well, that certainly overcomes what our advantage was from minimally invasive approach, where we address things through the groin. So I propose instead to use this endo anchor. I'm one of the principal investigators on the anchor registry, so that's a disclosure. I am involved in some of the research with this. But I do believe that this anchor or this screw can replicate the strength of a surgical anastomosis, as demonstrated in this experiment by Milas, that shows that the displacement force when an endo anchor is placed inside an endograft into the aortic wall, that displacement force required to remove it from a cadaveric aorta is greater than a displacement force of a hand-sewn anastomosis. So I do think that this screw can replicate some of that surgical strength, and I think that this may be an opportunity when we can learn something in terms of how to solve this problem of long-term durability. Ultimately, I think it's the concept of active fixation. That's what a surgical stitch is. Here's a gentleman that I treated, obviously years ago, didn't make it very long. You'll appreciate this as an autopsy specimen. And here's an anchor endograft right below a left renal artery. We opened it posteriorly, wondered about the strength of this active fixation. When we matched that diameter, here I am basically lifting the viscera off of the postmortem table to demonstrate the strength that active fixation can have. Again, I believe that can be replicated with something like a screw or an endo anchor. Here's one of the latest publications from the Anchor Registry, just this month's JVS. Tasiopoulos is the first author from the Anchor Registry. And so this is a multi-site registry, but we were able to identify 257 patients at 38 different sites and followed over 2 years, basically try to determine how much the aorta dilated after the treatment. These are all primary cases, and you can see that basically when you look at this table that's listed here, it's summarizing this statement that while there's some other important factors, one that I do believe is important are those patients who had more than 20% oversizing on their aortic endograft sizing compared to their normal diameter of the fixation zone. If you were oversized by that much, you had a 5 to 6 times greater impact on aortic dilatation 1 year after the procedure. Now, it varied with some circumstances, but my suggestion is that some of this impact of the radial force might be encouraging the progression of disease. So that's the other point that I think we need to be careful, specifically how we treat the paravisceral aorta. Again, I believe the aorta is a dynamic organ. Fluid dynamics may impact some of this late dilatation. We've seen some other images where we can see the respiratory variation that occurs relative to the paravisceral aorta, and I don't need to remind you that that's that segment of the aorta that's attached by the crura of the diaphragm, seems to be immobile, but we can have these other problems that occur relative to the pressure that occurs here, or the velocity of the blood flow, or finally the wall shear stress that can occur at different locations. I might also remind you that this can change with time. It might change after you change the environment and put the endograft in place. I would be remiss if I didn't add a little bit more to Dr. Lee's presentation, but it also makes me wonder about parallel grafts. How can these things ever work? Well, here's one of my own patients, 72-year-old lady, that we treated with really bad lung function, and you can see her paravisceral aorta was pretty diseased. That's it right here, where you can see both of her renals. She's got some thrombus, and it's pretty ugly, and there's her SMA. We did a 3-vessel snorkel with her to get her sealed all the way up above the SMA, and I have to tell you that I'm somewhat surprised that these things work as well as they do and that they are as durable as they are, because geometrically, they just don't make a lot of engineering sense to me. You can see this compression of this graft. This lady actually died of a respiratory failure about 3 years post-op, and her aneurysm remained stable. And again, I was quite impressed despite this. Here's another lady, one of the ones I showed you earlier. 4 snorkels are sitting right there, and she still functioned and kept all those vessels wide open. Again, doesn't make complete sense. I think we don't have a full understanding of the dynamic nature of that paravisceral aorta. So a table from the Pericles registry that really shows that this has been in widespread use for at least 10 years, and we're seeing mortalities that basically are less than 10% in most reports, and graft patency is at 90+% in this series. Again, I'm impressed. The Pericles registry is something interesting to gather information. The fenestrated graft soon came along, at least in the U.S. It was 2012. Did this make our parallel grafting obsolete? No, but that still clearly provides another option. And I believe that we can enjoy nice success, particularly on well-planned, well-controlled operations that have straight segments in reasonable attachment zones. These are some of the early reports from fenestrated studies. We can identify those going back, again, 15+ years. Very good technical success in branch patency, but again, it doesn't always fit. 2 publications relative to the ZFIN data, and that's the one in the JVS in 14 from the initial clinical trial that showed a relatively high reintervention rate at 22%, but still 97% renal artery patency. In the same year, post-approval outcomes were also reported, 57 patients. You can see that these are patients often treated outside of IFU, a slightly higher failure rate. I suggest once we get this technology and we start using it in different areas and in different boundaries, that's when we can have problems, and the wheels sometimes can come off and create some engineering situations that were not fully planned. And that's why we do see failures in these some of these new devices, some new, some old. And you can appreciate this might be related to aortic dilatation, or it might be also our mechanical structure as we put these stiff devices in dynamic organs. That's why I submit it's still important to use multiple different technologies or at least strategies, because I think we don't have the definite answer. And this is why I will use sometimes a combination of both fenestrated grafts and parallel grafts, and even use the anchors in those situations to potentially help with the gutter leaks. But ultimately, I think that this can be a potential solution till we have more of the dynamic aorta figured out. So my single conclusions are here. I do believe minimally invasive works. That's less than 1. Radial force seems to be less secure than sutures, and that's why I believe in some form of pretty active fixation. I do think the dynamic aortic environment requires careful adaptation. I don't think we've solved that problem yet. Thank you all for your attention.
Thanks a lot, Bill. So we're going to reiterate the same process now, but in the thoracic aorta with Matt Thompson. Matt, all yours.
Thanks, Eric. Thank you very much. And Mike, thanks very much for putting this on. It's a fantastic day. So it's kind of a challenge, I think, to describe the lessons that we've learned from these early pioneers up to the present day. And this is what happened to me when I was coming up here yesterday, or maybe. There you go. So I was waiting at John Wayne Airport in Orange County to get on a Southwest flight to San Jose, and I found the two pilots leaning out of the window from windows that I presumed were shut during the flight to clean the windscreen. And it kind of struck me that maybe the best results we get from endovascular therapy or anything else is when we combine brand new technology with tried and trusted methodology. So what have we learnt over 25 years? Well, the thoracic aorta is extremely tortuous, and in terms of graft design and delivery, we've found pretty much that we can treat this very tortuous anatomy with grafts that are manufactured entirely straight and are often on the platform designed for the abdominal aorta. And actually, we've come an awful long way in 25 years with graft design. So like Will and like Jason, I didn't put any of these in right at the very start. And my initial experience with thoracic endografting was with the Talent thoracic graft. And those of you that have experience with that will recognise perhaps that it wasn't entirely the best graft ever designed for the thoracic aorta. And yet we achieved surprisingly good results from this. But we've come a long way in terms of graft compliance, in terms of conformability, and particularly in terms of delivery systems. And actually, we've largely abolished through these lessons all of the early complications that made us all terrified of the thoracic aorta. So the grafts that didn't have tip capture at the start of it, that bent over virtually 180 degrees with thoracic blood flow, grafts that don't conform to the aortic arch, and that infamous pictures of artery on a stick that you got when trying to introduce very large thoracic grafts into tight iliac systems. And so clearly the lessons of graft design have been learnt and have been learnt well. I think one of the fascinating things when you think of how primitive thoracic grafts were in their early iteration is what an impact thoracic endografting made in the treatment of thoracic aortic disease. So this is still pretty early on in the evolution of thoracic endografts, and you can see here there's been a vast increase in the number of patients who get a TEVAR from 2004 to 2007. And what you'll note is that there's an almost exponential increase in the number of patients actually treated for thoracic disease. And this, of course, is why thoracic endografting has been so successful. There is a huge unmet patient need. So open surgery stays pretty much static whilst thoracic endografting grows. And the unmet need, I think, has been shown really eloquently in this month's paper in the JVS. This is from Mark Schummerhorn's group that has looked at the impact of TEVAR in treating patients with ruptured thoracic aneurysms. So you see in 93, 94, nearly 3/4 of patients who presented to US hospitals with a ruptured thoracic aneurysm actually underwent non-operative treatment. And as you'll realise, non-operative treatment of a ruptured thoracic aorta doesn't do well. But you can see that those figures have been dramatically changed over the past couple of decades with the introduction of TEVAR. Now, 43% of patients with a ruptured thoracic aneurysm get a TEVAR. But I think most importantly, the proportion of patients who are not treated has diminished by nearly 30%. And you can see in the green line on this graph a dramatic reduction in all-cause mortality. So what lessons have we learned? Well, informatics and evidence strategy, I think, is pretty interesting with regard to the thoracic aorta. If you compare what we do in the thoracic aorta with the infrarenal segment, the evidence strategy is very different. So there are very few randomized trials in the thoracic aortic space. The two classically quoted trials, Absorb and Instead, as Chris actually mentioned earlier, were difficult and both were underpowered with their initial analyses. Our best data actually is from registries. We mentioned IRAD earlier on today, but actually key in this space and actually very different to the infrarenal aorta is that the vast majority of the key trials that have been published are actually industry sponsored. So the INSTEAD study, the Virtue study, the Adsorb study, all come from industry, and there are very, very few governmentally sponsored randomized controls trials. And actually, I think that does present us with the problems because, as Vincent showed earlier on, all of the thoracic aortic guidelines are actually relatively underpowered in terms of low-level evidence, and we have a whole host of key unanswered questions that I'll come to later on. So what does that lead to? Well, that leads to an awful lot of our practice actually being defined by physician opinion. And whilst in some cases that can be correct, in some cases that leads to problems. And so I think collectively we should think about how we're going to improve our evidence base. One of the things that differentiates the thoracic aorta from the infrarenal space is the sheer number of pathologies that are all treated with the same type of endograft. So we have dissection, we have aneurysms, we have mycotic aneurysms, we have trauma, multiple different pathologies with differing therapeutic challenges and actually different requirements for endografts. But actually we treat all of these in a sort of one-size-fits-all type pathology. And actually I think this is potentially a problem. If you look at the incidence of retrograde type A dissection, you see it's essentially pathology specific, with acute aortic dissection having by far and away the highest incidence of retrograde type A dissection. There's also differences in terms of patient survival with various differing pathologies. So if you look at patients with thoracic aneurysms with acute or chronic dissections, the all-cause mortality rate is much, much higher in patients with aneurysms. So it's the dissection patients who will live longer. But actually, if you look at their requirement for reintervention, the reintervention rates in patients with dissection are much higher, and this is a paradox. So what does that mean? Well, essentially, I think it means we're not personalising care for patients with thoracic aortic disease. We are adopting a one-size-fits-all approach with our endografts, and that we're therefore not really following these fundamental principles of trying to select the best endograft for a particular patient. And so pathology-specific design, I think, will continue to be a hotly debated topic. One of the lessons we have learned, and I won't encroach on Matt's subject here, is about connective tissue disease. Certainly initially in these very difficult patients, there was great enthusiasm for TEVAR, but actually it became rapidly apparent that TEVAR is a relatively poor option in many of these patients with connective tissue diseases. Recent genetic studies has actually demonstrated that the magnitude of patients with thoracic aneurysms with a defined genetic mutation is vastly underappreciated. And I think there are some lessons from EVAR as well. I think the results of the EVAR-1 infrarenal trial came as a surprise to many, with concerns being raised about the long-term durability of these grafts. And actually, I think we should learn the same lessons in the thoracic space. We get very excited about branch grafts, about three-vessel, great vessel branches, but actually, we do need to remember that durability of TEVAR is still a concern. The number of papers that have reported long-term outcomes is really very low, and actually, we shouldn't give up on improved durability for TEVAR. So one of the consequences of expanding the patient population is not only our experience with endografting, but actually we've got a vastly increased and improved knowledge of the natural history of diseases. We didn't really understand, I think, quite how long patients with dissections live, what problems they run into, and the fact that dissection is essentially a disease that is incurable. So decision-making becomes very much more nuanced as the therapeutic choices expand. We have increased awareness of the natural history, and actually we do need to refine our classification systems in order to try and improve treatment. And actually, Ali presented a very eloquent and elegant classification system for traumatic aortic injury that's actually fundamentally changed the management of these patients. I think, as somebody mentioned earlier, we've got some way to go with regard to dissection. So the other lesson I think that most vascular surgeons have learnt is that dissection is far and away the most challenging thoracic pathology. I think initially it was the least familiar disease in the thoracic aorta to most vascular surgeons, and it also is the disease with the greatest range of heterogeneity in terms of pathophysiology, presentation and management. And undoubtedly, I think it's the most difficult and most nuanced pathology to treat with TEVAR. We have in reality this statement, no patient should ever be considered cured of the disease by Stanley Crawford, and that holds true. And I think we have a number of fundamental questions that still remain with dissection. So for example, how do we improve recognition and diagnosis in the acute phase and stop these patients being diagnosed with acute coronary syndrome? Should we actually try and personalise care of patients with dissection and use a different graft than we use with thoracic aneurysms? How do you quantify the plasticity of the acutely dissected aorta? And that goes straight into what Christoph spoke about today as what is the most effective management for patients with uncomplicated subacute type B dissection. And then finally, as Mark spoke earlier, can we use TEVAR in patients with chronic false lumen aneurysms, and how do we manage effectively the false lumen? Our evidence base for this is really weak at the moment. So finally, I think this is probably the biggest lesson in terms of unmet need. The hardest, most difficult complications to prevent and manage are neurologic with the thoracic aorta. Both spinal cord ischemia and stroke are devastating, and they also reduce patients' long-term survival by about 20% over 5 years. I think we have made some quite significant progress in mitigating spinal cord ischemia with regard to our understanding of the disease, making sure that we manage CSF pressure, recruit collaterals, and stage these procedures. But actually, I don't see a big paradigm shift in the prevention and treatment of stroke following TEVAR, and I think that's where we really need a technological leap. So finally, those lessons were all lessons from the future. As we're in Stanford, I think it's good. I'm the only one, I think, who's finished with an Einstein quote. So thank you very much.
Thank you very much. Now we will get lessons learned about aortic rupture. Manny Maida.
Thanks, Chris, and thanks, Mike, for putting together a great event. I cannot tell you how humbled and honored I am to be here. So the topic I was given is lessons learned from aortic rupture, and it's remarkable that 2017 marks 200 years to the date that Ashley Cooper first tried to fix an aortoiliac aneurysm. It was actually an iliac aneurysm that he tied off. The patient died 2 days later from an ischemic leg and complications off, and it didn't take much but 136 years later when Henry Basin was the first who successfully used a homograft the year after Cooley and DeBakey introduced that to successfully treat the first aortic aneurysm, ruptured aortic aneurysm. Since, of course, Cooley and DeBakey popularized this, and it was yet again another 40 years that Yusuf Whitaker, Tudor, and their group, as well as, rumor has it, Mike Marin and Frank Vieth, on the same day were doing the ruptured aneurysm in 2 different parts of the world on the same patient. Yusuf so the publication obviously in 1994 was of the ruptured aneurysm UK versus in US, but it just tells you how much parallel work was being done at the same time through collaborations. And certainly the first publication of a larger series was from Montefiore with Oki and Frank Vieth that talked about the 12 ruptured and emergent cases that they had done, and that simply changed things quite a bit. 1999 was also the year that I started my fellowship with Frank Vieth and Tak Oki, and so it was a great time to train, make homemade grafts, and really go through the process of learning endovascular evolution. And 20th century, I would say, was all about diagnosis and surgical repair. And 21st century became all about the EVAR and TEVAR feasibility, safety, and efficacy. And everyone in this room has pushed those boundaries to get a better sense of that. When it comes to aortic rupture, we know that ruptured EVAR and TEVAR are well documented, well beyond just feasibility, safety, and even efficacy. We know that it's associated with significant reduction in morbidity and mortality. But this didn't just happen, and there was a lot of work that went on behind the scenes. So in mid-1990s, so 95 to 2000, I would say the feasibility of ruptured EVAR was being tested, and open surgical repair still remained the gold standard. And there were a few centers that were pushing these boundaries on all parts of the world, and this caught on pretty quick. The focus was on how to get occlusion, and that was a transbrachial approach. And all of us, I think, in that time that were doing this, the approach was only through a brachial. The decision was whether you go right or left brachial, really, and you want to cross the arch. And the other big decision at that time was whether we need bifurcated grafts, because do we have the time to cannulate the gate, or do we need an aortouniiliac device? Hence, the MEGS device at Montefiore had played a little role in trying to define whether that had some use. And off-the-shelf devices, as much as we all have them today, that was just not feasible. That just was not available at the time. And of course, the implementation of operating rooms that would be set up to do endo as well as open was a big to-do. Just to have small rooms with setup of to do both things was something that was evolving. The next 5 years, from 2000 to 2005, is when regionalization of care came into play when it came to ruptured aneurysms. And centers that were ahead of the curve, 5 years ahead of the curve of the rest, started to become regionalized centers because they could do ruptured EVAR, and there were transfers that were set. Of course, the standardization approach was one that was not something that was much thought about. And I can tell you this came completely out of a fluke when we published the first paper on that. And that was because the first ruptured EVAR that I did after I finished my training, so I finished in 2001. On January 6, 2002 was the first rupture I did at Albany. And I remember fighting with the anesthesiologist over the arm because the patient was hemodynamically unstable. They wanted both arms for brachial lines and IVs, and I wanted just one of the arms for a balloon. And just because I couldn't get that arm and trying to avoid a fist fight with the anesthesiologist, I ended up going transfemoral and certainly never looked back. But I think there was standardization of care, and which way to just get occlusion control were things that used to be thought about, things that are very second nature today. These simple things were things that we were discovering, and we were discovering many of the limitations of doing these procedures. It wasn't quite simple to plan an EVAR and just do it. Just from imaging to having the equipment to having trained staff, all those were big issues. And certainly we were discovering the complications. Although we've known about abdominal compartment syndrome for decades, the reality is with ruptured EVAR, abdominal compartment syndrome got highlighted very fast. And certainly the iliac on a stick concept, when you are not measured well and when the sheet sizes are 24 and you have to use them emergently, these were all things that then we had to salvage. Of course, during the same time, as much as it was a struggle for endovascular aneurysm repair for rupture to gain foothold, although it was obvious that this has value, emergence of ruptured TEVAR became a very easy thing to do. Certainly, I think because vascular surgeons had an avenue to treat thoracics, they had the devices more readily available. And before the devices were approved in the US, I think what was really being used are modified devices and cuffs that were aortic cuffs by sewing conduits that are in the iliac so the delivery systems could go up higher. And this is how some of the earlier cases were done. And in the next 10 years, there were centers like Starnes group that took this standardization approach and then quantified and measured it, that standardization of care matters, standardization of resources matter, and they showed morbidity and mortality differences before and after. And of course, during this time, once again, ruptured TEVAR had an easier path to acceptance. But at this time, there were also more and more reports of rupture following EVAR. So as much as EVAR was on a rise, the first into second generation devices started to see the wrath of some of the limitations, and certainly when done under emergent circumstances. So this created some paucity in this. And as much as that was happening, of course, the hybrid ORs, the multi-center registries, the national databases, the meta-analyses, and certainly the randomized trials were being formulated at the same time by so many of you guys in this room to really identify whether ruptured EVAR truly has some benefit or not. So this really divided, I would say in about 2004, 2005, this divided all of us in this room into two categories. People who believed that ruptured EVAR and open surgical repair were comparable versus ones that said, no, ruptured EVAR is clearly better without necessarily having randomized trial data or other large data sets. And people who thought that ruptured EVAR is better really pushed for saying this has to be a first approach in all rupture patients versus even some went further in saying this should be the only treatment for all aneurysms. So let's look at some of the data that evolved over time. I won't have time to go over everything, but I'll highlight some of the key articles, I think, and large articles. So this was a system. This was a meta-analysis of all the review that was done and published in 2008 that Sadat put together, 23 published trials. And in that, certainly, it highlighted that morbidity, mortality, ICU length of stay, hospital length of stay is better and less with ruptured EVAR. What's interesting is at that time, only 10% of all patients were just with ruptured aneurysms were being done by endovascular means. This data set's a little bit more mature, and you can see that this is published in 2010. Once again, looking at ruptured EVAR, showing that 23% acceptance just over the course of the next few years, 10 to 20%, almost doubling of acceptance of ruptured EVAR being done. Frank Vieth at the same time was traveling all over the world, and I remember getting the call from him, and I'm sure all of you guys probably in the room got the same call, and that was that he wanted to have something that was more tangible than single center experiences. So he put together this collected world experience of ruptured EVAR, where 49 centers came in, nearly 1,700 procedures were evaluated, over 1,000 EVAR for rupture and 763 open surgical repair. And this was the largest study at that time that clearly showed that there was a disparity in ruptured EVAR versus open surgical repair, but of course there were lots of biases for all of us who were endo enthusiasts versus open enthusiasts in driving this. Overall mortality in that series was 21% for ruptured EVAR versus 36% for open surgical repair. What was really critical, and I think probably one of the most important parts in this manuscript, which was probably missed a little bit, was that the need of aortic occlusion balloon for the first time was defined as to what that is. And only 1 out of 5 people needed the aortic occlusion balloon, and this allowed us to tap into our ability to say we actually have the time to do some of the imaging and other things. More patients are hemodynamically stable than not. Beyond that, NISQIP Gupta looked at the NISQIP database, a large subset of 1,400 patients, 45 of which were considered unstable, to try to better define if unstable patients can also have ruptured EVAR. And in stable patients, ruptured EVAR mortality was better, 16% versus 26% to open surgical repair. But even in unstable patient, ruptured EVAR mortality, although higher than with stable patients, at 36% was far better when comparing unstable to unstable open surgical repair. So there clearly was a vector that was pointing in the direction that says a ruptured EVAR clearly has advantage. Of course, there are many other lessons to be learned in whom we can use to treat these complex cases, and anatomical limitations become a real deal, because around this time in 2005 to 2010, we were also recognizing that if we go outside the IFU of treating patients, and the outcomes are not necessarily as good and the complications rates are much higher. But with that, what we also needed to recognize is that patients with rupture don't have a lot of choice. So do we really have an opportunity to go through having within the IFU or outside the IFU? So many centers, like ourselves, looked at favorable versus unfavorable anatomy and looking at ruptured EVAR versus open surgical repair. What we found that in favorable anatomy, the mortality is better than in unfavorable anatomy, but overall, the survival is much better than with open surgical repair, short-term as well as cumulative at 3 years. So this, once again, I think data that was coming out like this from many different centers tended to tell us that we should continue to push the envelope here. This was the first paper that came out that I think even to date is the one paper that has long-term survival advantage for ruptured EVAR versus open surgical repair. If you take a closer look and take the first 30 days out, there's actually no difference. And this truly highlights the importance of what happens in that immediate period. The decision tree to say I'm going to do ruptured EVAR versus open surgical repair is pretty clear, and the disparity is set right at the onstart. So maybe having endo-first strategy is a good strategy if you can develop systems that can cultivate that model and lead to good outcomes. Now, people that bought into that ruptured EVAR is the first approach and the better approach. They actually pushed the boundaries. 2 centers, 14-year experience was put together in looking at patients that came in with ruptured aneurysms. 473 patients presented, 1998 to 2009. There was a period that both treatments were offered, but from 2009 to 2011, all patients with ruptured aneurysms either underwent endovascular repair or no treatment at all. If you take a close look at this, the 30-day mortality when both treatments were offered was 32%, and 30-day mortality when only ruptured aneurysm was offered was 27%. Really no difference. That was a decision that they had made. What was also critically important in this is that the times were changing, and 24% of the patients in the later cohort when only ruptured EVAR was done had pararenal and juxtarenal aortic aneurysms that required chimney grafts and fenestrations and other things. So these really were much, much more complex anatomies that these institutions were beginning to treat with fairly good outcomes in pushing, once again, the boundaries. And of course, there have been more than now three clearly recognized randomized trials, HX, ECAR, and IMPROVE, of which I won't bore you with the data set, but we know who is championed in fighting and debating the fact that even though they are randomized trials, there are some fundamental limitations of randomization in rupture situations. And Frank Veith has highlighted that over the course of the last 5 years, clearly highlighting the point that when we analyze data on intent to treat versus on the treatment that patients received, there are clear differences in what the outcomes are. So in all these trials, if you look at the treatment that patients got, ruptured EVAR wins. If you look at an analysis that's based on intent to treat, then ruptured EVAR is comparable to open surgical repair. In my thought process of this, I would say the way things have worked is we have evolved over the course of technology, techniques, better understanding the complications, and developing better processes to improve the outcomes over the course of what has happened in ruptured EVAR. Use of aortic occlusion balloon is critical. It went from transbrachial to mostly transfemoral, and it went from a transfemoral approach to better understanding how to support the balloon, how to utilize the balloon at specific parts of the procedure that gives you more time to do other adjunctive things that are needed during the procedure, and that certainly has been very helpful. The other thing is also in us understanding the complications, and this was one of the earliest papers that was out that actually tried to identify patients that develop abdominal compartment syndrome. Who are these patients, and can we really learn something from them? And what we had learned is that patients who use that require aortic occlusion balloon have massive blood transfusion and are coagulopathic during the procedure, have a significantly higher risk of developing abdominal compartment syndrome. So these influence our decisions on how to manage these patients, whether you simply need to do a laparotomy in all patients, where early on some centers were doing, or you need to be selective. Other complications were rupture after EVAR, and certainly stent graft explantation was one idea. Redo endovascular was another idea that was evolving at the same time. The surgeons at that time were very defiant in the sense that if you have a failure for EVAR, then I would say 10 years ago, vast majority of surgeons would say, you got to just take that graft out and do an open surgical repair. That clearly has changed. This was a very high-risk patient of mine that had ruptured an aneurysm, and she was so frail that we were afraid that if we simply clamped the aorta, that she was not going to survive. So in this, we simply put mattress, interrupted sutures around the neck, opened the graft, and simply did an endoaneurysmorphing, and it worked. And she survived for many years until I think I lost track of where she is. And certainly developing processes in place, checklists of how we do things to manage that patient when they enter the ER to the time they enter the OR and what happens thereafter, I think has had a big impact. Impact so much so that we certainly start to push the boundary of doing ruptured EVAR in straightforward cases versus complex cases, and the utilization of chimneys, periscopes, and all these other parallel graft concepts has clearly come into play in managing many of these patients over time. So, and I think the ruptured TEVAR has had it much easier to not necessarily prove its position in life because it's been on the coattails of ruptured EVAR, and things certainly have been easier. If you could bring up, I just want to end with this one case that I want to show you guys. That us evolving from a position of simply trying to put a balloon up and simply trying to seal a stent graft to, I'll tell you, the first case I just did coming back to Albany Medical Center as I've re-entered a different phase in my life, is a patient that is 85 years old, extremely brittle, extremely sick. She had a type A aortic dissection and 5-centimeter aneurysm. She was taken to Albany Med. The cardiac surgeons made a decision that she was way too high risk to do anything. And this is her 85 years old, home oxygen dependent, prior CABG, very kyphotic, and they thought that if they opened the chest and tried to do this, she probably would not survive the operation, and the family appropriately made a decision to go home and die. She was made comfort care. It's just that she didn't die. And they called me about 3 weeks afterwards. I repeated a CAT scan, and that looks like either a contained rupture or simply the false lumen that has now expanded from 4.5 centimeters 3 weeks ago to now 9.5 centimeters. And of course, I begged the cardiac surgeons to maybe come up with some solution, because the last thing I was looking to do is this case. And Ali's smiling there because the value of this is that we lean on each other so much. I called Ali that night as I had come up with a game plan to go to the operating room, and I said, listen, this is what I'm planning on doing. I need a second opinion to just bounce this by and whether this would work. Now, Ali, when I called you, what I didn't know is that this patient not only had a lima to LAD, but had a free vein bypass coming off the ascending aorta to the circ. So in finding that circ, which I was able to, and certainly trying to identify the proximal distal landing zones, the key was in trying to be very close and within pretty much the sinotubular junction, because the dissection was really torn at that point, and a chimney graft that comes from the ascending aorta, a parallel graft, into that free vein bypass to the circ. And this patient was in the hospital 4 days and 1 week out into the office. So I think we have gone in managing ruptures and acute emergencies from simply trying to control the hemorrhage to getting into the complexities of not just ascending aorta and dissections, but also maybe managing some of the complexities of coronaries that go along with it. I want to thank you.
Thank you, Manny. So the last presenter of this session, at least, is Matt Eagleton from the Cleveland Clinic to tell us everything about connective tissue disease.
I'd like to thank Mike for the opportunity to participate in this. So when we think about endovascular therapy or any therapy for patients with connective tissue disease, we have to change our thought process. We're no longer thinking about the durability of our grafts. We have to think about the durability of the aorta. This is an accelerated disease process in these patients. There are a number of genetic abnormalities and syndromes that are associated with aortopathies, and this list is growing, and our ability to identify these genetic defects is growing. We just don't know what to do with all of them, and we don't know how to identify all of them based on their phenotypic expression. So how do we know if one of our patients has these abnormalities? And one of the best ways to do this is just through screening. I think this is important. It's probably the time when you can make the biggest difference in this patient's life is through screening and not through the surgery that you're going to do or potentially going to do. And there are proposed indications for genetic testing in patients with aortopathies. The first one is the medical history and physical exam findings consistent with a syndromic form of aortopathy. I find that overwhelming and easier said than done because many of these syndromes have overlapping phenotypic characteristics. They all look the same to me, at least many of them look the same to me, and I can't see somebody in my office and say, oh yeah, you've got Marfan's, you've got Loeys-Dietz, you've got Ehlers-Danlos, or you've got one of the other number of growing genetic defects out there. So there are other characteristics that we have to look for. Early age of onset, less than 60 years old or 65 years old of a thoracic aortic aneurysm, patient with any aneurysm under the age of 50, patients with an aortic aneurysm and a family history of aneurysms or family history of syndromic features. Patients with multiple aneurysms, and then cystic medial degeneration or histopathologic conditions of the native aorta. Any of those suggest you should have this patient undergo genetic counseling and get tested for genetic disease. So does knowing there is a genetic defect affect our outcomes and management? And the quick answer again is yes, it absolutely does. One is through patient education and planning, and patient education and family planning are very important in this group. Life planning is important and survival planning is important. If we look at the outcomes, say, of a more severe form like Ehlers-Danlos, and this is from Gustavo's paper, we see that by 40 years of age, freedom from intervention, any intervention, is only 37%. It's terrible. Many of these are going to have some catastrophic event by the time they're 40 years old. This is true for vascular complications as well. Freedom from vascular complication by the age of 40 in this group of patients is only 39%. And they clearly fall off the normal survival curve of the average population for their age. This also affects our medical intervention and surveillance that we offer these people, and this is where we can also make a difference in their long-term survival. We can offer them different medical therapies than we might offer the average patient, and different surveillance protocols than we might offer the average aneurysm patient. And this can improve survival. If we look specifically at Marfan syndrome patient, in 1972, 50% of Marfan syndrome patients were dead by the age of 40. From 1972 to 1995, with the beginning of screening and counseling of these patients, the median cumulative probability of surviving was extended from 48 to 72 years. That's a tremendous difference. As a result of the survival, though, a number of Marfan syndrome patients requiring secondary intervention due to newer residual dissections and aneurysms is increasing, and this alters the durability of our repairs. And it may be particularly important when we choose an endovascular approach for these patients. Just knowing the presence of the disease affects outcomes in those patients with Ehlers-Danlos syndrome. Emergency procedures were more likely performed when the diagnosis of vascular Ehlers-Danlos syndrome was not known, 81% versus 41%. Emergency procedures were more likely to be done open if we didn't know the diagnosis, and post-operative complications were higher in those patients we didn't know the diagnosis. And it does alter our surgical decision making. We tend to be more aggressive with these patients, intervening at smaller aortas. How are our surgical outcomes? And this can be varied because they're rare occurring diseases. There's not a large series of patients out there describing long-term outcomes. Many of these groups are probably heterogeneous groups of genetic abnormalities that were just haphazardly called Marfan syndrome or one of the other aortopathies. And then even fewer of these are treated with an endovascular approach over time, so we don't have a lot of information about the outcomes associated with its use. If we look at specifically at Ehlers-Danlos, there's not a lot of direct evaluation. Brooke in 2010, 40 patients. There were about 8 aortas treated, and they were all treated open. Gustavo's paper in 2005, 132 vascular complications in 24 patients, 23 aortic complications, but only 5 ended up having aortic repair. All were done open. There are successful case reports available for EVAR and TVAR, but we're not hearing about the failures, only the rare success. What about surgical outcomes for mixed series of patients, including a number of different genetic and syndromic problems? The biggest series is actually by Eric Roselli, published just recently in 2016, 527 patients that underwent repair with connective tissue disease. A large number of these, though, were aortic root replacements. With their 121, they were arch or a little bit more distal thoracic aortic disease for a whole variety of reasons. This is a bit unbalanced, though 88% of these were thought to have Marfan syndrome with few number of Loeys-Dietz and vascular Ehlers-Danlos syndrome. Most of these were also open surgeries with few hybrid or endovascular approaches or pre-hybrid approaches that underwent first stage elephant trunk procedures. If we look at outcomes from this, these patients all do well. They're young patients. They're usually in their 30s or early 40s with an operative mortality of only 2.5%. By 10 years, though, the probability of reintervention was 61%, probability of survival was only 62%, and event-free survival was a dismal 24% in this group. Clearly, repair in these patients is only palliative. If we look beyond the arch, and this is unpublished data, this was actually a series that was started by Roy that we are in the process of finishing. He ended his analysis of this in 2012. And it's just over 50 patients with a mix of Marfan's, Ehlers-Danlos, and Loeys-Dietz syndrome. Again, they present at a young age. If we look, this spans not just the aorta, but also other beds of the vasculature as well, but compares open and endo with regard to treatment and outcomes. And we see that about 15% of the thoracic aortas were treated in an endovascular fashion. About 25% of the thoracoabdominals were treated in endovascular, but we get a lot more aggressive when it gets into the abdominal and iliac segment, where 50% of these are approached with an endovascular fashion. And why we're more aggressive there, I'm not entirely sure, although maybe we just feel safer that we can bail them out with an open approach if it fails. If we look at freedom from secondary procedures in this group of patients, by 10 years, about 60 to 70% of these patients are free from a secondary procedure. So they have actually done quite well with regard to that. But if we break it down, if they underwent open versus endovascular repair, we see that 60% occurs at 1 year in the endovascular approach. So they fail early. But by 10 years, we see failure rates that are equivalent between the two groups. So should endovascular aortic repair be considered in this group of patients at all? Well, we have experts in this room that have weighed in on this. So the American Heart Association consensus statement on thoracic aortic pathology and Marfan syndrome and connective tissue disorders, we should not be doing this, except perhaps in the rare instance when it's emergent. Across the pond in Europe, they agree with us on this, and they say don't use this in patients with connective tissue disorder. So just like my 12-year-old son, when you can tell him not to do anything, don't do it, it's bad. Despite this, we go ahead and do it anyway. And we'll probably continue to do this and continue to push the limits. So how are our outcomes with thoracic endografting and infrarenal abdominal aortic endografting in patients with connective tissue disorders? The majority of these have been published in patients with Marfan syndrome, so I'll focus on Marfan syndrome. If we look at outcomes for patients with open surgical repair in Marfan syndrome, they do very well, and it's because they're young patients, they can tolerate a large surgery, and they have excellent 5-year survivals. But even with open surgery, they do have recurrences, and they do have needs for secondary intervention. We find in this series of 83 patients that 53% of these patients at 7 years follow-up required a secondary procedure. It occurred more commonly in patients that were performed in an emergent fashion than an elective fashion, but it's still a large number of patients that require a reintervention. So open surgery is not immune to this. If we look at outcomes for endovascular repair, tough to say. The series are very small. Most are under 20 patients. Many of these were done in an urgent fashion, with 30-day mortalities being affected by the urgency of the case. If we look at a little bit further follow-up in these patients, again, even that's not long. I think most of these are less than 3 years follow-up. Only one series made it out to 51 months. We see higher rates of secondary endoleaks, in particular type 1 endoleaks, where they're anywhere from 8 to nearly 20%. And those patients requiring another endovascular procedure or surgical conversion approach 30 to 50%. So again, these patients are failing, and they're failing early. So open versus TEVAR, which is better? There's no evaluation of an endo-first approach for aortopathies, except for the rare case where it was inserted. Usually it was inserted on an emergent basis. So we don't know about elective in planning to do this approach. Both require reintervention, perhaps sooner with the endovascular repair, perhaps not, and both require close follow-up because they both will ultimately fail and require further interventions in most cases. So when should we consider endovascular therapy? Perhaps in the emergency setting to save the life, like a complicated type E dissection or a ruptured aneurysm. Perhaps as a bridge to open surgery or a bridge to the next surgery that the patient's going to get done, providing them with close clinical follow-up and close imaging follow-up. We should avoid elective use in those patients with any questionable neck anatomy. We should consider those with prior open repair to bridge intervening aortic segments that are failing, that we have a solid, secure landing zone. The question becomes, when should we consider it as a primary surgery in an elective setting? And I don't know the answer to that, and I don't think any of us know the answer to that yet. Word of caution about using it, though. This is an example of a patient with an ACTA2 mutation that our aortic team was involved in. He had a type A dissection with distal extension, underwent an emergent ascending and arch replacement with an elephant trunk graft, did fine. Underwent a secondary procedure with a thoracic endograft in preparation of a total aortic replacement. You can see the endograft in there. There was a little endotrash placed in the false lumen to seal that off. This is post-op CT scan just prior to the patient going home. The case went very smoothly for him. 2 days later, he showed back up, however. 2 days after this CAT scan where everything looked great. At this point, though, he is paraplegic, has ischemic legs bilaterally, and ongoing abdominal pain, and has had a rapid expansion of his abdominal aorta greater than 5 millimeters in 2 days, occlusion of the distal aorta, and a new dissection of his superior mesenteric artery. I think my response from that is these are an unpredictable nature of this disease, and don't trust it whether you're going to approach it open or endo. Thank you.
Thank you, Matt. We're going to quickly change moderators and then crack on.
So we're going to bring Tim Tudor back, and we're going to hear about unmet needs and future developments in the thoracoabdominal aorta. Tim?
All right. As my disclosure as usual. The focus of this talk is opportunities for the future. And really, you know, it's like when you're in school and you get the report back, it says room for improvement. Endovascular repair of TAAA is not perfect. It can't be applied in every patient, and it does not produce uniformly satisfactory outcomes. Let me go through a couple of these things. Many of the patients lack the anatomic substrate for a successful repair. The mortality and morbidity rates are low. They are falling, but there are notable exceptions to that. The long-term efficacy and durability, again, has been shockingly good, but there are specific failure modes that we have to look out for. And of course, these are very expensive procedures. both in the utilization of imaging resources and all of the components. These are not uniformly available. There are barriers, some of which come from the skill and availability of equipment, but most of which come from the fact that the devices are not approved for general sale. And of course, we're not talking about one device, one technology, one technique. We're talking about a family of devices, and to some extent you have to match the procedure to fit the patient, and that's the way to achieve success. But just remember, there's more than one way to skin a cat, and there again, you have the author of that comment. You know what, you can't mention his name too often in this context. He's done a lot. So I'm going to go through some of these options. Any endovascular repair of an aneurysm that has branches will require branches. The branches are either on the stent graft or they're surgical bypass debranching exercises. So anatomic versus extra-anatomic. We've seen the general battle waged between, at least early on, between modular and unibody devices. I think modular is pretty much won out because it is the more versatile and flexible approach. Balloon expanded versus self-expanded, we're really talking there about fenestrations versus cuffs. Now, I have a distinct preference for the cuffs, and we'll talk about that a little bit, but it is an open debate. And then, especially in places where these devices are not commercially available, the surgeon-modified versus the pre-made. And here are your basic options: fenestrations, cuffs, and of course cuffs down in the iliac arteries. Here's a fenestration with a covered stent, and the way that this thing attaches itself, one component to the other, requires that there is a little flange created by overdistension here. It requires that the branch traverse almost perpendicular to the long axis of the primary stent graft, and that has some consequences. This transverse orientation means that you have to be very precise. It's not like a cuff where you're running up or down the aorta and you have an opportunity to adjust the trajectory before you get to your target. No, your target's right there and you have to be right there. If, on the other hand, there is a large space to bridge, then this rigid little object applies some leverage to its attachment site, and that too can cause branch distortion. So here's just a depiction of a covered stent, balloon expandable covered stent projecting into a renal artery, and you can see the change in angle at the distal end there that I think represents a potential source of failure. Another potential source of failure is the fact that when a balloon expanded stent is crushed, it remains crushed. Well, the alternative, cuffs, essentially they're characterized by providing an overlap zone and being oriented in an axial direction. Here's the first, many years ago, back in 2000. This was the angio, this was the post-op CT scan. So you can see here we've tried to recreate the healthy anatomy. And as I said, your basic thing is you're coming through a cuff, usually via the brachial artery. Well, that axial artery comes with some obligations too. First of all, the branches are not necessarily going to be oriented in an axial direction relative to the stent graft. It means the stent graft has to bend, which really means you're going to want to have a self-expanding stent in there, not a balloon-expanded one. The fact that it has to take this, that it has to change orientation, does mean that there is a potential for kinking at the angulation between those two things. The other is that once the branch exits the stent graft, it's in the perigraft space. That's good. You can use that space to navigate, but a lot of patients will not have adequate space there. And you'll find yourself working in a crushed perigraft space where your catheter maneuvers are not so easily performed. And of course, these things disrupt the seal between the stent graft and the surrounding aorta. So if you're going to do this, once you've bought one cuff, you've really bought 4 of them, and you're up into the supraceliac coverage. Now, there are exceptions to that, but you have to recognize that this lack of coaptation between the stent graft and the surrounding aorta has consequences. However, there are advantages. The stent graft can be a little high, a little low. Krasi Vanchev pointed this out to me, that this is the only reason why I prefer cuffs, is because you don't have to think about it very much before you go and do the case. And the thing will forgive you. And it will forgive you because the clock position on your target vessels is usually fairly reproducible. That allows you to have a fairly reproducible stent graft design. Here's an example of where these branches really come into their own. They can assume all sorts of weird and wonderful shapes en route to the target artery. One of the things that we've seen again and again in endovascular aneurysm repair is that people actually do learn from their experience, and there has been a convergent evolution of device design. And so you'll see all sorts of new devices, and then you'll see devices that were once new, and now they're new again. So here's one of the variants where you have one little attachment point and a distance from another attachment point to allow yourself some variability in the direction. Here's another one where this little machine gun turret allows some variability in direction. The cuffs can, of course, point in an upward direction, as in here, although we found that there's some hemodynamic consequences to that might give you pause. The cuffs can have catheters to guide you into them. The cuffs can be inside, outside, or they can be entirely on the inside, and you heard about this. And this is one approach for those patients where the paragraph space is not very large. Here's another illustration of an upgoing cuff, that one on the inside. And going up into the thoracic aorta, or you can have these multiple access sites, turn it around. You can do the same thing in the thoracoabdominal aorta. This is an old patent, and this is a new device. And you can see that these old ideas are being recapitulated. Here again, something old. Here again, the newly invented version of that. Again, this dates back years. Michael Lawrence Brown probably remember this case. Here is the new version of the same thing. So bear in mind, if you want to know how these new ones are going to perform, you can go and take a look and see how they performed the first time before they were abandoned. If you look at the exclusion criteria, and obviously these can vary, you'll find that the primary reason for excluding a patient from repair with one of these devices is that the patient has more than the standard 2 renal arteries. And when that happens, the renal arteries often will become too small to receive a branch. There are other characteristics that we find unhelpful, but many of those are actually modifiable. In fact, many of these patients, they start out with unsuitable anatomy, but you can do a couple of stage procedures and you can get them to where you need them to go. One example of that is a patient with an aortic dissection. We used to exclude all those patients from repair. We no longer regard dissection as a contraindication to multi-branch repair. Just means that you've got to do another procedure. You've got to take the unsuitable anatomy and make it suitable. So you've got to fenestrate between the lumens. You've got to dilate areas that are narrowed. You've got to prepare your implantation sites. Once you've done that, the procedure itself, the definitive procedure, is actually often easier than when the primary disease is a regular old atherosclerotic aneurysm. And we've looked at our series. We've got 18 of these now. The results were, in terms of duration of operation and everything else, were entirely the same as for the regular group. Well, what about the morbidity and possibly mortality? Well, in the short term, neurologic complications continue to plague our experience, primarily paraplegia, although that does seem to be declining. In the long term, we've suffered from branch patency, and the fenestrated ones tend to suffer from branch stability. You're looking at about a 10% failure rate. although that has changed recently with some changes in technique, we found that it's a much reduced rate. And then, as you heard discussed already, this is a disease of the entire aorta, and if you get progression of disease outside of your primary field of repair, that can extend actually to undermine the repair itself. That I don't need to comment on, just to say that collaterals develop rather rapidly, and you can take advantage of that by staging the procedure in a variety of ways. When I talk about staged repair, I'm actually talking about the elimination of anatomic obstacles, so it's a slightly different approach. And here's an example of the branch patency that I'm talking about. There's one branch, beautiful straight branch headed down to the renal artery, made from a fluency. There's another one made from a viabond that's horrible and bent and kinked in a number of ways. Which one of these occluded? Well, of course, it was the beautiful straight one. The reason for that is that the artery downstream from that artificially straightened segment takes the brunt of the angulation. So if you have a graft that will conform, go with it. The occlusion rates are substantially lower. Regulatory, I'm not going to go into it too much, except to say that it's really, really hard for one company to put all the necessary components in one box, do one trial, and get one approval. And until we are allowed to trial these components separately, I think it's going to be really, really hard to get through some of the regulatory obstacles, partly because the manufacturers are all in competition, and some of them have patents and some of them have technology, and they're not very good at sharing. So you need to move forward. How do you know you're going in the right direction? Well, when the experts in open repair suddenly become experts in endovascular repair, you know that you're on the right track. When the published results of open repair start to improve, right, you know the technique's not changing, but the results are getting better and better and better. Well, that's only because they have to publish results that are comparable with the endovascular results. And you find your referral population gets sicker and sicker and their aneurysms get larger and larger. Take that as a good sign. That's an expression of the faith in your skills from the referring doctors. And then when you get to really know your patients well, because you've seen them every year for the last 15 years, that's also a sign that you're doing something right. Thank you.
In keeping with this session's theme of unmet needs, we'll now turn to Rod White from UCLA, who's going to tell us what's up today for treating type A aortic dissection.
Thanks very much, Mike, for all this work. This is my new institution. I want to quote Tom Fogarty here. I'm conflicted when I get up in the morning, so that's my conflict of interest slide. I'd like to give Dorothy credit for what I'm going to talk about. These are all based on PSIDE work that over a period of time has been worked out. If you want to read the Federal Registry, you can get the details on that. And what I'll show you to start off, just to complete Mike's historical slides, is we had one of these early on, and it was about 2 years' worth of animal implantation, and Tom came down, and we were making these grafts like everybody else and shoving them in a catheter, and there was 2 years' worth of implantation data that went into these early cases. That's one here, scrubbed in a case, and Tom here. We then did a series of bifurcated studies with Tom, and his quote was always, "We want to be the first one to know when this is going to fail." So one of the things with the bifurcated technology was just to look with the IVUS there and see where there's an offset. That was the first challenge to solve. And then to be able to deliver these small bifurcated grafts into a dog and get 2-year patency and then eventually carry that on. Now, those first clinical studies were, as others know, been published, and this was a presentation Tom made at the American Surgical. After 4 PSIDEs sequentially with the FDA, this is the ascending graft IDE that we submitted about 3 years ago. And the concept's pretty simple, to put a graft in the ascending aorta and be able to treat pathologies there. There were a series of devices that Medtronic made for us, and these are longer than you'd suspect, and I'll talk about that in a minute, but these were 6, 8, and 10 cms long with an open stent on the end. So, you'd think some of those are too long, and actually they're not. There was a lot of testing that went into the master file that Medtronic had, and all the challenges, the anatomy and the arch, the curve, we have to look at all these other branches. And then what happens in the ascending aorta, and the FDA was concerned about this, is that with the difference in pulsatility, are these things going to be stable and stay in place? So that the first tests that were done to look at that, and we made these on centerline measurements. And the reason I mentioned that to you is they're really short. The way these devices conform, and I'll show you, it's the outer curve that makes a difference in the terms of that length. So it's not the center line or the inner curve, but it's really the outer curve that's most important. And because the FDA was worried about stability, we were granted to be able to look at tubular pathology. So that included pseudoaneurysms, penetrating ulcers, or eventually, as I'll show you the topic today, the ascending dissections. And it's critical to have the hybrid room, the capability to do the 3D registration, and this kind of characteristic is important. And the other is a TEE for the ascending, because these patients come, they're obviously an extremis, they go to the OR, they are set up with cardiac anesthesia, and the first thing you look at is a TEE, and that's how we make a decision about really, even without other imaging, whether these patients are candidates or not. This is a patient we did early on with an intramural hematoma. There's a pretty good landing zone there, you can see, and this was obviously the deployment. Now these systems, you have to cross the aortic valve, so one of the things that was really important in our experience was having TAVI experience also, to be able to be familiar with pacing the patient, crossing the valve, knowing how to handle that, because you're always going to impinge on the valve and you want to be able to control that during the case. These are a series of some patients. This is one out to 2 years with a post-surgical lesion. This is another one. We were able to hit an intramural hematoma in a patient, and these are just sequential images I'm showing out to 2 years now. So the first thing was we were able to know these were stable. You could hit where you want to put them, and that they heal and stay in place. And that was the first academic question that came along. So the challenge then was, can these actually work in ascending dissections? And as you all know, we'd like to have the ones on that left-hand panel, these short ones, they're all in the ascending aorta. You've got lots of room. But many of them are around the arch and extend into the head. So one of the challenges there is to make sure if we're going to put a graft that there's continuity into the brachiocephalic vessels after we put that device in, much like you would with a tubular graft. The first patient I'll show you is a 65-year-old guy. Had been in the hospital after a hip fracture. He wasn't in very good health, and he had sudden onset chest pain. This was the ideal case. It was the middle of the day. Everybody was around. Cardiac surgeon called me and told me he's in the OR. He's an extremis. He looks like on the TE, maybe we can put in an endograft. And so I'll show you this series of images. This is a colorized 3D M2S after the fact. So we didn't have it before, but it shows you in red where that tear was in the ascending aorta with the continuity of the vessels into the head and then around the aorta. So he clearly on the imaging we had was a characteristic, and this is the TEE, so that you can see that tear we thought was up about 2.5 centimeters, looked ideal to be able to do that. This is the valve on a transverse view, so we're looking to make sure we don't have perivalvular leak or something that if we put it in is going to be, and then this is the layout just like the TAVI case to be able to hit that appropriately. This is the angiogram. You're used to seeing these. So he's got an ascending dissection. There is continuity through the head, and we confirmed that with the IVUS. That top image on the left there shows you that we're coming up around the arch, and it does have continuity. We put the device in, and this is the first view. The device is open above the valve, and then higher on, it expanded and it's completely open. And what happened at that point, everybody was prepared for about a 6-hour case. The patient immediately straightened out. We watched him for about 15 minutes. They broke down the pump and we went out. And it was the first thing that really convinced us there could be a major advantage of being able to do these. This is that transverse view again after we put the device in, just to make sure everything was okay with the valve. This is the IVUS, so the view on the bottom panel there is at the coronary. The graft starts right above there, and you can see it's pretty well expanded. And then on the angiogram, it is pretty well fully expanded. There's flow into the head and around the continuity, so we're left with what would be that type B dissection, but he had opened up again, the malperfusion went away, and this shows then the IVUS going up around the arch where there is again continuity into the brachiocephalic vessels. So we were confident that we were okay to leave and watch him. This is his CT at 30 days, and you can see there's still a residual type B, but there is continuity to the head. The graft is nearly fully expanded, and that ascending dissection, at least around, it's excluded. This is that same patient at a year. And now you can see it's nearly completely expanded. He still have the residual type B we're thinking about. And then on that right-hand panel now in the ascending aorta, there's been complete expansion with resolution. So the ability for that thing to sit there again out to a year with this patient remaining stable, and now we consider him for the rest of the procedure. The second's an 84-year-old lady. She came in with acute chest pain. She was had really vascular collapse, and somebody had ordered in the progress of this center to the MR because they didn't want to give her CT, which doesn't make much sense, but she survived the MR, and that's the imaging we have going in. And you can see on the MR that she did have the acute dissection. It went around the arch and involves some of the descending there. And this is her with an ascending graft, and then also in that descending component, a descending graft 2 days later. She again was one of these patients straightened out right away, came out of the OR and had this result. Now, she's obviously got some other anatomic things down in her iliacs that we haven't approached yet, but that patient in this case has continued to do well. She's about 8 months out. Third one, this is an 82-year-old female. Again, these are all vascular collapse patients, so they end up running to the OR. And this was after a TAVI valve. So she had had her TAVI valve put in and she didn't straighten out. They knew there was a problem. They shot an angio. I tried to load these images, but it wouldn't come up. But what you saw was pretty straightforward. You could see on the angio and with the imaging they had that she had an acute dissection. And this is a short graph we put in to cover that. And again, this patient, this is her CT now at a month out, and you can see where she's, in that case, with a real short dissection afterwards, completely healed that lesion and continues to do well. So now we're talking about potentially what comes next. Everybody's thinking, well, you add a valve to this and maybe it'll, turn into a bent tall, and there's a lot of schematic ways to look at it, but the potential to do that probably is very apparent in terms of what we can do now, because if the anatomy is appropriate and this keeps going on. The other thing with the horizontal hearts, and we had talked to the FDA and our IDE now to be able to do transapical approach, because some of these potentially would be easier to get in and dealing with the angles. So we haven't done that yet, but that's a consideration. Everybody's familiar with that approach. So in conclusion, in this IDE where we've treated now 11 patients over about 2 years, we've been able to show that these things sit stable in regular tubular pathologies. And I think the ability to be able to translate this into the acute dissections is for real. There's a paper I tried to load up. We tried to get it. Hulan just did a paper that estimates about 30-some% of these patients on a large series, if you look at their anatomy, would be amenable with the kind of anatomy I'm looking at now. I know, Ali, we had talked about this earlier, and from what we've seen, just surveying patients with current tube graft technology, if we could do 30 or 40% that way, that's a big leap and would really revolutionize, I think, the way we're going to treat these. So the early feasibility looks like we can do that in these first patients. With the help of the FDA, these have the B3 category CMS approval, and so you get paid for these at the same time, and hopefully based on what's going on, we're going to be able to translate this to a larger study. There's 4 other centers now that are taking the idea and are going to submit it, and hopefully this will be able to be expanded into a larger study, similar to what we had done with the dissections earlier in the PSIDEs. So, Dorothy, that's your fault. This is Tom's slide. I'll leave with that. Thank you.
Thanks, Ron. Next, we're going to hear about unmet needs and future developments of valves and conduits. Eric Roselli.
Thanks, and thanks, Rod, for introducing the topic. This isn't a CME event, but we know that endovascular devices have been used in the ascending aorta starting with many of the things that have started here. It's also occurred in many other places. But I think when we talk about whether endovascular root replacement is nearby, I think we have to ask two questions. One is, should we be doing it? Should we be thinking about it? And number two is, can we do it? And I think those are two very different questions, but important ones to understand. So first, when trying to understand about whether we should be treating this disease with an endovascular approach, let's look at what the outcomes are for open surgery. The Japanese database looked at a large series of nearly 5,000 patients undergoing thoracic aortic surgery. 10% of them underwent aortic root surgery. The operative mortality was less than 9%, only 7% in the root, but major morbidity was 30%. The risks were the need for emergency surgery, which was about 25% of the patients in that root cohort, renal dysfunction, and unexpected CABG. So there is a subset of patients who we might want to consider a less invasive approach for. Similarly, Amanda Caceres and a group of aortic surgeons from several centers looked at the STS database over an 11-year period of time, looked at nearly 32,000 patients. It's a little arbitrary, but they divided the group into about 20,000 cases that were called high risk based on their age, the presence of endocarditis, the presence of aortic stenosis, dialysis, multi-valve operations, reoperations, or emergency status. The rest were considered low risk. And they compared those undergoing valve-preserving operations with those undergoing composite valve graft operations. In both groups, whether the valve was replaced along with the aortic root or whether it was spared, that high-risk group, the mortality was around 10 or 12%. There were no differences. The patients who had aortic stenosis underwent a composite valve graft. The mortality is 5.1%. This would be the group of patients we'd be considering this endo composite valve graft for, a patient where you tie a TAVR to an endo device. Or maybe the patients who need an emergency composite valve graft where the mortality was even higher, 22, 23%. Again, many of those are probably the type A dissection patients that you talked about, Rod. Another series looked at the relationship between volume and outcome in patients undergoing aortic root surgery, again an STS database study with over 13,000 patients. And they did look at the volume as a continuum. However, they broke them down into quartiles, and there was a clear association, even though the overall mortality was a little less than 5%, but a clear association between the volume and the outcomes. So less than 6 cases a year, mortality was 6%, greater than 30 cases a year was 3%, and those greater than 30 cases a year centers accounted for, it was only 3% of the centers accounted for 25% of those operations that are being performed. So this device is going to be probably something, if and when it comes about, something like our branched experience with other parts of the aorta, something that's done at centers of excellence just because of the understanding of the disease itself. At the Cleveland Clinic, where we do about 700 or 800 proximal aortic surgeries a year, most of those are open. We do some endosurgery as well. We've demonstrated in this paper where we looked at 4 different root operations, biologic, mechanical, homograft, and valve-preserving operations, excellent outcomes with a mortality of less than 1%, a stroke rate less than 1.5. So in an experienced center with multiple options, the surgical approaches are excellent. That homograft group is of patients who are particularly complicated. Many of these patients underwent reoperations, and these operations are durable with good survival and a low risk for reoperation, even now that we see the majority of these patients are getting bioprosthetic valves. There will be nothing like this operation where we preserve the living valve, but that's a young subset of patients. And so again, we have to appreciate, I think, first and foremost, before we start talking about what kind of devices will look like for the aortic root, that there is a complex, heterogeneous population of patients. We know that elective ascending aorta replacement is safe even in patients undergoing multi-component operations. We've demonstrated that in analysis of our open outcomes. And so again, this idea that we can provide it, we first have to ask, should we provide these kind of procedures? And we have to understand who those patients are. The risks and benefits have to be tailored to the specific patient, not only based on the diseases that they have, but their anatomy and local expertise at the various centers. Again, we can provide minimally invasive open surgery in patients with great outcomes, and we do that more often. I do agree with what Rod was just saying, that there is an unmet need in the aortic dissection population. This is an IRAD collection of outcomes data that's old. We looked at it similarly in our high volume center, and we found that with our multidisciplinary team approach to aortic dissection, we were able to reduce the mortality for aortic dissections to less than 5% in pretty much all populations except this group, this non-operative type A group. And so we looked at those patients in detail to try and understand who they are, and we presented this at a European Association meeting last year. And we found that in our series, where we're very aggressive about treating pretty much all comers with type A dissections, that there was still about 8% of patients who were not getting offered surgery. Most of those patients were transferred from elsewhere, and most of those were DeBakey type 1s. When we looked very specifically through the records to try to determine why they were not offered surgery, we found that 2/3 of those, actually, the reasons for inoperability were very high-risk reasons, not prohibitive reasons. What I mean by that is prohibitive is the 90-year-old who comes from the nursing home who's demented. No one ever should touch that patient. That's like a TAVR Group C, unfit for anything. But a lot of these people, they had various reasons for not being offered surgery. And if you talked to them maybe a year ago, they were still cutting the grass. So those are the folks who we want to have a better solution for. And so it was good to see that 2/3 of these patients, if we had a better solution that they could tolerate a less invasive operation, that we might be able to offer them something. We also looked at the scans. Unfortunately, we only had 24 scans because a lot of these people, when they're sent off to hospice or something, the scan disappears. But in those 24 patients, with a loose criteria for whether they would have been treatable with an ideal TEVAR device, that is, the tear was above the sinotubular junction, essentially was our main criteria, and that we had access, and their aorta wasn't excessively large. We were able to cover that entry tear theoretically in a majority of patients. So in those 24 scans, we thought 19 of them, if we had the right kind of device that we could park consistently at the sinotubular junction, we could treat them. We've seen in our experience with the use of Stent-Grafts in the ascending aorta, which is now actually 40 patients, but I've compiled some data on the first 38, 15 of which had acute aortic syndrome, that this certainly is feasible. And some of the things we learned from that experience is that there are kind of two different groups of challenges to these patients with these devices. One are the sort of aorta and patient-related details, and the other are the procedure-related details with regards to the devices and the delivery systems that are available. Certainly, we need to understand the patient better. We need to understand this anatomic space better. Again, Rod had pointed out the importance of understanding sort of how to measure these aortas. And I think it's really important to understand that the ascending aorta is not a straight structure. It is nothing like the descending aorta. This is a specimen of an aorta I cut out at some point. To demonstrate this, I took it out in toto instead of splitting it down the middle. And you can see the white arrows are pointing to the posterior wall. You can see that the posterior wall is often 1/3 of the length of the anterior wall. And this is not even a very big aneurysm. This is like one of these 4.5 centimeter aortas in a bicuspid patient. In the aneurysmal aorta or the diseased aorta, it's even more impressive, the difference between the components of the aorta. When we looked at our outcomes for that series of type A dissections, we've seen that the folks who had more proximal disease with regards to where their disease was involved or where we placed the devices, that's where all the bad outcomes came from. And so, this patient, even with coronary grafts that are important, if they have a pseudoaneurysm at the distal suture line, it's easy to come up with a device to repair that problem. but the patients that have more proximal disease do worse. I know sometimes this seems obvious, but I think we need to really think about it as we're moving our technology forward, that we can't just call everything zone 0 that's in front of the brachiocephalic artery. We really should think about a subclassification for zone 0 being zone A being the root, zone B being the first half, and zone 0C being that second half of the ascending aorta. As we gain more experience, I think we're going to see differences in how those patients do. There's a lot more to learn about the patient-related factors and the aorta-related factors, but I think the devices also need to be much better and much different, a lot different than what we currently have. A tall Z stent is not going to conform to that curved ascending aorta. Also, the ascending aorta is way more elastic, and the environment within those devices is much more hostile than anything we've seen in other parts of the aorta. We need to understand whether radial force is enough and how much, and whether it has to be variable across the segments of the aorta. Perhaps we need to consider active fixation, like we heard from Will Jordan in other segments of the aorta. I could see it being maybe even more important here. It is important that the device is curved, or at least will be able to take a curved shape. And I think that if we really want to be all-inclusive in our treatment, we have to have branch devices. If we're talking about a composite valve graft, there's no more important branch than the coronary arteries. I'll argue they're even more important than the arch branch vessels. Of course, the devices have to be able to comply inside the aorta. I just show that because it's a particularly ugly device poking through the side of an aortic wall. Any autopsy picture, I think, sort of brings that point home. And the delivery and the deployment needs to be completely different than what we do. In our ascending experience, about a third of our patients have had transapical delivery. It does help a little bit with alignment, but it's not nearly enough with the current state of devices. We've resorted to transfemoral for most of our ascending approaches because I think that we can imagine a better fit now that we understand sort of how those devices deploy in that space. The systems have to be exceedingly precise. They should be repositionable, and they have to be flexible and steerable. We know that with the ascending, we have to be coaxial with the sinotubular junction. Mike Dake said it himself, that we can say, yeah, look, it can be done, but we have to ask ourselves whether the current TVAR technology is ready for the proximal aorta. I don't think it's even close, but we get by with what we need to do. We need more devices, better devices, and especially in the aortic root. So this is a patient, this is the first patient to put an ascending device in. You can see that dissection goes all the way down to the aortic annulus. We were able to cover the tear in that patient and made the AI better, but many of these patients are going to have root involvement with their disease. They have a need. This is an 84-year-old patient who had a TAVR, had a good outcome with it. 6 months later, she came in with acute type A dissection. She had tears in the ascending and descending. I came up with this idea for her. She's still alive a year later. I'm still not sure how. She's got some flow around the dissection in her arch. But, us providing mechanical solutions to this disease with a biochemical etiology is not enough. Certainly, we need to understand the mechanisms of these diseases a lot better. This is not an audience to sort of get into details about this because we're focused on being the folks who provide those mechanical solutions. But I think one of the themes that we have heard in the background is the fact that this disease is not cured by the mechanical solutions we provide. We need to continue to understand the disease better. If we do, I think we'll understand the mechanics of the places where we're putting these devices better. We need to understand the conformability of the proximal aorta. We need to understand the elasticity. We need to understand the tissue characteristics. And then maybe we'll have some device that looks like this. This is a picture that Lars has that's sort of, cut and pasted. This is not a real device. But there are patents out there. This was actually Lars Svensson's patent about a composite valve graft device for the aortic root with a valve and branches for the coronaries. And this is a combination of devices that are patents from both Roy Greenberg and Lars Svensson. For Roy's idea was to separate the annulus landing zone from the valve itself. And Lars' other patent here is for a device that doesn't get crushed by a TVAR. But if we're really going to have a composite valve graft device, and not just a valve plus an ascending graft, depending on the disease we treat, especially if we're talking about aneurysm disease, we need to not only think about proximal fixation, which can be achieved with a TAVR device in the left ventricular outflow tract, but we have to think about seal. And so, and coronary patents. I think these are the two important issues that come up when we think about whether we can do this. I've talked about whether we should. I think if we want to think about whether we can, we need to understand what's happening when we're putting devices in the left ventricular outflow tract. Paravalvular leak is huge. And all the focus in these papers that look at the paravalvular leak and transcatheter valve surgery look at moderate or worse paravalvular leak. Those rates are high enough at around 10 to 20%. They've been associated with higher mortality. They progress over time. It's something that can't be ignored. So we're not even close to good enough with just parking the device in there to treat the valve, let alone tying something that's going to seal in the root. However, there are a lot of new devices in that valve market that are working to reduce paravalvular leak, and they're getting better. This is a couple of slides. As one of the investigators, this was just presented at EuroPCR. This Lotus device is one that has an adaptive seal and has helped to reduce paravalvular leak. The results are great. It's only 2% versus 11% for moderate to severe paravalvular leak. However, if you look at the pictures on the side, even in that device, there's a 10% mild paravalvular leak. That's a huge endo leak if you're talking about a peri-device leak, any other part of the aorta. That is not going to seal a root aneurysm. So 29% pacemaker. 29 pacemaker rate, absolutely. So we need to match the devices to the patients. This is a guy who had a valve put in many years ago, a patient of mine, who came in with the valve to hyst just because his annulus and his aorta grew. So all these problems that we see with EVAR, where the aortas continue to grow, are going to continue to be problems with our devices. I know that you can get away with gutters in the abdominal aorta. I don't think we're going to get away with gutters alongside coronary arteries in the aortic root. Can we put covered stents in the coronary arteries? Most of the interventional cardiologists would tell you that they all occlude, but that's not totally true. There's case reports of Viabonds being used to treat giant coronary artery aneurysms, like in this case here, and a couple other case reports. And then this is a series that looks at a newer device. It's a stainless steel device with 2 layers of sandwiched PTFE. And these stents, these Gravmaster stents, they come in various sizes. And the indications are to treat a coronary that's greater than 2.75 millimeters. So all of a sudden, the idea of having a covered stent that you can marry to a TAVR and ascending stent graft may be feasible. Finally, I got to come back to one more question about whether the should. We already talked about whether we can or should. And then there's the question about cost. Again, if we're talking about should we do this, we know endografts are expensive. TAVR devices are even more expensive, and surgical grafts are cheap. Although direct hospital cost is something that doesn't come into that at all. And there's many things to think about. I think that composite valve grafts are something we can consider, but we need to consider many layers deep, and we have a long way to go. Even in Cleveland, that's really far on the horizon. Thank you.
So next, we're going to ask Frank Vieth to talk about the impact of endografting on vascular therapy.
Well, thanks, Ron. And all of you may have noted that I wasn't on the program of this Festgraft celebrating endografts. But that's because I wasn't coming. My wife Carol and I had long-standing plans in the New York mountains that couldn't be changed on this date, and so I declined Mike's offer. 2 weeks ago, I saw the Festgraft program, how great it was, and that all of my friends and colleagues were coming. Of course, I was very upset not to be part of it, Carol saw how upset I was, and when I showed her the program and who was coming, she said, "This is a meeting you cannot miss. You must go." So I called Mike, and he kindly was willing to fit me in. So, Mike, thanks for that, and congratulations on what is really a great meeting. For the next few minutes, I'm going to give you one person's view of the impact of endografts on vascular treatment in general and vascular surgery in particular. First, some history. In 1992, I had the good fortune to lead the team of Perotti, Schoenholz, Marin, and others to do the first US EVAR. The success of that procedure led us to undertake an endovascular grafting program to treat a variety of aneurysms, occlusive and traumatic arterial lesions in patients that were otherwise impossible or very difficult to treat. We made the endografts ourselves from PTFE grafts and Palmes stents, following the principles of Perotti with various modifications. Now, as Mike Marin has documented, and he made one mistake in his talk, he did not have a full head of hair when he worked with us, even though he showed that slide. Anyhow, as Mike has documented, these procedures were remarkably effective in otherwise untreatable patients. And seeing these successes was an epiphany to me, was really a lightning bolt that hit me in the head, and it made me realize that vascular surgery as we knew it was going to change. And I'll say more about that in a moment. Now, you have and will hear lots about successes with aortic aneurysm endografts today, so I will tell you about an early trauma patient's endograft, which was particularly eye-opening for me. This case in 1993, I got a call from our city hospital about a 26-year-old man who was shot multiple times in the right shoulder and chest. He was in shock. Blood was pumping out from a wound under his clavicle. And it turns out our group was responsible for vascular coverage in the city hospital, and all my partners, like Mike, were either away or doing another difficult case. So I told the guys who called me, put pressure on the wound, take the patient to the OR, get IR and tell him to bring his equipment, set up the C-arm. And I then gathered in a shopping bag stents, balloons, PTFE graft, some sheaths and wires. And I went to the front of our hospital, got in a gypsy cab because regular taxis didn't come to that part of the Bronx. It was too dangerous. And 10 minutes later, I was in the city hospital operating room, and we did a rather rapid transfemoral subclavian arteriogram, which you can see here, the extravasation from the subclavian under the clavicle, and that thing distally is a branch. It's not the distal subclavian. So we quickly put up an over-the-wire balloon, inflated it in the subclavian artery. That stopped the bleeding. I then cut down on the brachial artery, did a retrograde arteriogram, and was fortunate to easily pass a wire across the lesion. You can see the branch on this arteriogram, and a fairly short segment of damaged subclavian artery. I then put this PTFE graft, sutured it to a Palmes stent, put it in a plastic tube as a sheath, mounted it on a balloon catheter, and under primitive fluoro, placed it across the lesion and expanded it. And this relatively simple procedure solved this problem, which would have been fairly complicated in this otherwise critically injured patient. So cases like this made us realize that the treatment of vascular lesions was going to change, and that endografts and the associated endovascular techniques and technology would be transformational. And in 1994, Mike and I published many articles and talked widely about our endograft experience, including a presidential address to the Eastern Vascular Society, remember this was 1994, on transluminally placed endovascular stented grafts and their impact on vascular surgery. And again in 1994, it was shocking that few paid much attention to these talks and articles. And we sent an abstract to the SVS. It didn't even make the cut of abstracts that were shown to the program committee. Of course, it didn't get accepted. We then tried to present our new and what we thought was transforming treatment to a very prestigious group called the Vascular Surgery Biology Club, with all the hotshot leaders and program directors in vascular surgery. Chris Zarens, Wesley Moore were there. I brought Juan and Mike to the meeting with me, and we thought we were going to show these guys the new world. It was shocking. Unanimously, they thought we were either lying or crazy, and it really made the three of us very depressed. We went out afterwards and had a beer. I was very depressed. Juan was a little depressed. Mike Marin said, well, that's the way people are. Anyhow, in 1996, I was fortunate to be elected SVS president at a time when our endograft experience made me realize, and was making me realize, that vascular surgeons had to change or risk becoming extinct. And I wanted to talk about that and the future of vascular surgery in my presidential address. And in discussing this with Mike, who was a friend as well as a colleague, he said, why don't you link it with Charles Darwin? So I said, that's a good idea. And I gave my presidential address on Charles Darwin and vascular surgery. And in that address, I likened medical specialties to species. I indicated that specialties like species had to evolve to avoid extinction and survive. And I made 3 predictions and associated recommendations. The first was that we work in dedicated multispecialty vascular centers. In a perfect world, kumbaya world, if all specialties worked together, it would be good for all 3 specialties. We'd learn from each other, and it would be especially good for patients. However, it's not a perfect world. And this multi-specialty center idea did not work in most places for lots of reasons, mostly related to human nature, greed, power, desire for power, and medical tribalism. My second recommendation was that vascular surgery become more independent and a separate specialty, separate from general and cardiac surgery. It's a long story. The bottom line is it didn't work very well, and we're still a subordinate specialty. My third recommendation was that vascular surgeons become endocompetent. And in that 1996 presidential address, I predicted that 40 to 70% of the open operations we were doing would be replaced by endovascular procedures, so that to survive, vascular surgeons would have to become endocompetent and do these procedures. And shockingly, again, this recommendation was greeted by disdain, resistance, and even hostility by most of the senior vascular surgery leadership and many senior vascular surgeons. However, this resistance was gradually overcome. Vascular surgery took this advice and is therefore a surviving specialty today. Surprisingly, my estimate in 1996 that 40 to 70% of open operations would be replaced and many others improved or simplified by endovascular adjuncts was wrong, not on the high side, as all the vascular leaders were saying, but on the low side. And now, as you know, 65 to 90% of open operations have been replaced, and you see it here in the various vascular beds, what it is today, 65 to 90%. What about the future? With the improved technology that we have been hearing about and hear about every day and have seen at this meeting, the percentage of vascular lesions treated endovascularly will increase even more in 10 years. And I predict by 2027, as you can see in the various vascular beds here, 75 to 95% of vascular lesions that used to be treated open will be treated endovascularly. So my conclusions are that endografts have transformed the way most vascular lesions are treated. Endografts played a major role in leading to wider adoption of other endovascular treatments. Endografts have had a major impact on vascular surgery, allowing it to evolve in ways assuring its survival. And on a personal level, I'm most fortunate to have played a role in the development of endografts and the impact they've had on the treatment of vascular lesions and the evolution of vascular specialties. So congratulations to Mike Dake, not only for his seminal role in endografting, but also for putting on this creative Festgraft meeting. Mike, thanks for inviting me.